All right, well, we are going to go ahead and get started. So thank you all for joining today. And on behalf of United for Medical Research, I want to welcome you to today's briefing. So I'm Alex Curry. I'm the Senior Director of Federal Relations for Vanderbilt University Medical Center, but also serving as the President for United for Medical Research this year, or UMR. And UMR is a coalition of research institutions, patient and health advocacy groups, and members of the life science industry. Our focus as a group is to help highlight the groundbreaking work of the nation's biomedical research enterprise and work with policymakers to articulate the importance of steady and sustainable investments in the budget for the NIH and keeping the US a global leader in this space. So in support of that mission, we produce a variety of information for policymakers to help illuminate the return on investment for federally funded medical research. And today we are excited to unveil our latest report, which, as I hope you know, examines the impact of NIH-funded research on rural states in particular. So we undertook this effort after hearing from a number of members from rural offices that sometimes the connection between NIH-funded research and the direct benefits back home out in the hustings in some of these rural parts of America isn't as well understood as it could be. So that got us thinking about how, in some parts of the country, be it Massachusetts or California, maybe there's a well understood connection between the economies and vibrant biomedical research hubs, but that in states, whether it be Arkansas or Mississippi or other rural states, maybe that's less apparent. However, our report says and shows that the impact in rural America for NIH research is no less significant, in fact. And so that is why we are incredibly pleased to have Senator Cindy Hyde-Smith of Mississippi here with us today. I know the senator is just in between votes, so can't spend much time with us at all. The senator knows firsthand how important strong NIH funding is to the researchers and academic institutions in her state, but also to Mississippi patients and family who stand to benefit, of course, from the treatments and cures that NIH research brings about. As a member of the Senate Appropriations Committee and its Subcommittee on Labor, HHS, and Education, Senator Hyde-Smith is an important voice here on the Hill for the research community, and we're just so thrilled to have you with us today. So, Senator, if you'd like to say a few words before you need to go vote.
Thank you very much for that kind introduction. And we are in between votes. We had two, and they said, back to back, you can't leave. I said, hey, I'll be right back, because I know how they linger before they come in. We've got enough time to do everything that we need to do in the next few minutes. But thank you for allowing me to be part of this, because I do come from rural America, as most of our southeastern states that I'm familiar with. But I grew up in a small town, and I know how vitally important rural health is. And I just appreciate everybody's work on this. We are cattle farmers, ranchers. We run a stockyard, and I cannot tell you how many times I've had to use our local emergency room because it's a dangerous living. And, it's just a lot of the things we do in rural areas. We don't get hurt a little, we get hurt a lot. And because of the occupations and the hazards that come with that wonderful way of life that we enjoy. But the medical research, the budgets for this is so critical. And I want you to know that that moment is not wasted on me or my colleagues that experience the same things that we do as everything you do. And we're very grateful for that. And, we just want really good, improved care at, when those opportunities, but at the cost that's affordable, that's rational, that's practical, that we can go in there and know we've got good care and we can actually afford that good care. And there's so many moving parts to making those things come together, and I understand that. But it's such a huge economic impact on our area as well. The number of employees we have at our rural hospitals, it's normally the economic engine of that town or that county. And it's so important because, first of all, we must have the critical care access, and the employees that also come along with that is just the bonus that we have. But my gratitude is deep. I've had so many experiences from growing up as a child where we had a paper mill. We have a member of Congress, a new member of Congress from Tennessee. His name is Mark Green, and he and I grew up together. And when we were children, his dad lost his arm in the paper machine at the local paper mill. And those are some of the things that I just referenced back in my life to what it means to have access to that rural care. It's just been a few years ago that my father-in-law was gored by a bull. The horn of the bull went through the front of his leg, came out the back of his leg. And, you just don't think about those things really happening. And, we think of the motorcycle accidents. We think of things that are pretty common. But things like the paper machines in rural areas, the wood yards, the stock yards that we experience. So the research is so vital. Today is really important of what you're unveiling. And, the things, just the updates. I want you to know that I want to be an advocate for you because I've lived it. I know it firsthand. And of all the realms of things that are affected by that, during Katrina, was one of the major things in Mississippi where we really utilized every resource, all hands on deck. The rural health facilities, they stood so tall. They really did. I'll just share one brief story with you that we didn't have electricity in the town where I live because of the hurricane, because of Katrina, but we had generators. But generators have to have fuel. And on farms where we farm, we can store off-road diesel, as we refer to it as. And, we have pumps on the back of trucks. And there's actually a picture of me at our local hospital in the pouring down rain, pumping that pump on the back of a pickup, filling up that generator at the hospital so we could keep going. So, we're pretty resourceful. People look at the rural areas and they think, bless their hearts and, those type of things. But we have a lot of good professionals. We have all the professionals everybody else has. But we are very, very resourceful. And that morning when I got the call that we're low on fuel, the hospital generator is low on fuel, immediately I thought, it is illegal as it can be. We're not supposed to use that off-road tax, that off-road fuel in a generator anywhere. But Hurricane Katrina just hit, and I thought, I want to see the person who thinks they're big enough to come in here and stop me. That person didn't show up. But I just appreciate what you do, and I certainly appreciate the time spent with you this morning. But I am one grateful U.S. Senator for everything that you spend time on doing, because I've been the recipient of it, but I know how important it is. Please know I'm your advocate, I'm your friend, and I'm a pretty good fighter. Thanks so much.
Thank you so much, Senator. We really appreciate you joining us this morning and for your words. Continuing on with our program, every year UMR publishes a report detailing the NIH's role in sustaining the U.S. economy in terms of economic activity produced as well as jobs supported. And that report provides top-line data for every single state and the district. In fact, we'll be releasing the 2019 edition of that report here very shortly, so please stay tuned for that. However, the report we are unveiling today takes a smaller sample size and provides a deep dive into 7 rural states. And so those states are, I'll list them very briefly, Alabama, Arkansas, Kentucky, Maine, Mississippi, Montana, and West Virginia. And the whole point and rationale of this report is to look at a detailed impact of NIH research in those states and their communities. So here to walk us through the report's findings is its author, economist Charles Lawton, who's immediately to my right, who's an expert in fiscal impact studies and economic policy. And I'll note that Chuck is also a native of one of these rural states that is profiled in the report. So as a resident of Maine, Chuck has a keen understanding of the economic factors affecting rural communities. And until recently, I understand you were actually a published columnist in one of your local newspapers, the Portland Press Herald, where you opined on a number of economic issues. So we're delighted to have you with us today, and I'm going to turn it over to Chuck to give a short presentation and overview of the scope and findings of the report.
Thanks, Alex, and all of you from United for Medical Research. It's been a pleasure to do work with you, and I'm happy to be here. I'm sure you're all thrilled at the thought of the luncheon speaker being an economist that's going to combine with your sandwiches to put you to sleep immediately. But before I even begin there, I have to point out that I am from rural Maine, but in spite of what may appear here, this is actually not Maine. Maine is up here. And so in case of emergency or you have to have a call for help, send it up here to Maine. However, I would like to try to summarize the report, and I'll ask not to be Groucho Marx and have somebody come and throw cards down from the ceiling, but the charts that I've prepared here, that were prepared for us from the report, go over the central elements of the report. First of all, rather than the 50 states and District of Columbia, United for Medical Research wanted to focus on a selection of rural states, hopefully representative of a variety of regions of the state, not all of one area. But most significantly, I think, those states are smaller, $120 billion average GDP versus $420 for the rest of the states. 2.8 million population instead of 7 for the rest of the states. 40% rural, 48% rural versus 22% for the rest of the states. And by and large, they receive less NIH funding on average than the non-rural states, the non-selected states, 107 million on average in 2017 versus a 578 average for the rest of the states. So smaller areas, smaller population, smaller economies, less money, NIH money. However, I think that money can be said to be equally or more important in many ways to those states than the money that is received by the other states. And what we're looking at is economic activity, basically GDP, gross domestic product, jobs, development of the labor market, state and local revenues, and fundamentally the health potential that's available from NIH funding. If we can flip to the next slide. Thanks, Sue. That average of $107 million in NIH funding received, and that's the average of those 7 states, generated in 2017, and this includes both the operational spending, how much was actually provided by NIH for medical research, and the capital equipment that goes along with that. The laboratories, the buildings that were built, we used a 4-year average of capital spending to incorporate so that we're including not just the researchers, but the contractors, the builders, the electricians, the tradespeople, the work that gets done in building the research facility as well as just operating them. That activity supported almost 1,700 jobs and generated $22 million in state and local taxes. Now, that's not in addition to the 245, that's some of that, but every one of those $245 million has some impact, some gas tax, some income tax, some property tax that's paid in that stream of activity that goes to state and local governments in the 7 states. So the activity itself is an economic benefit. Secondly, I think there's a very important point to be made about the human capital impact of NIH funding. If you look at the Department of Labor census data on average pay by the scientific R&D sector, in all of those states, those 7 states, it's twice as high as the average for all sectors in the state. So NIH-funded activity, both the NIH funding and the indirect benefits that are provided through vendors and through employee spending, produce high-paying jobs, not just any jobs, but they're raising the salaries statewide because they're higher than the average, and even more particularly for workers under the age of 25, they're 1.8 times higher, so that not only are they higher paying jobs, but they have higher pay for younger workers. And in states that are, generally speaking, older, generally speaking, not growing as rapidly, high-paying jobs for young people are an important distributional effect. And in many ways, I think that's the key to what for me is the fundamental economic message of the period in the United States since the Great Recession, and that is concentration of economic activity in the major metropolitan areas. And in many ways, for me, that's embodied in the absolute frenzy over the Amazon HQ2 bizarre competition that's occurred over the last 2 years. Every state, every town, all across the nation bid for this 50,000 jobs and billions of dollars in investment, only to find out it wasn't going to be 1, it's going to be 2, and then only to have the number 2 bail out because they didn't want it after all of that competition, or at least they didn't have a political ducks in a row to get it. And to me, the essence of NIH-funded research as an economic driver is that it's already distributed all the way across the state. Not equally, not everybody, but every state gets some. And in the rural states, that benefit, and if we can look at the next slide, has effects not just in the area of jobs and sales for local businesses, but also for the potential for fiscal benefits. In the 7 rural states, even though their average payment per Medicare, Medicaid beneficiary was lower than the average of the rest of the states, their beneficiaries got less money, but that money took up 50% more of the state and local budget in those rural states than it did in the other states. So that the potential of NIH funding to cure a disease, to provide a medical benefit, has a greater relative impact fiscally in the rural areas, because solving that could allow you to get your dollar to go farther in serving the beneficiaries of Medicare and Medicaid in your state. And then in the economic development side of it, and I was talking to Carlos here, that his plant in Alabama is not a research center, but it distributes equipment. And there are many, many jobs in the supply chain servicing research center that are located in rural areas, and that as NIH funding grows across the country, serve those supply chain linked businesses. And finally, I would say that the biomedical clusters, the large number of relatively small grants, if you look at, and there's an appendix in the report that talks about the recipient institutions within the state. And in California, the hundreds of millions to 4 or 5 different institutions. In the rural states, there are 1 or 2 big, usually associated with a university or a health center. But a lot of very small grantees, which indicate at least the potential for startup businesses flowing from medical research. And that, again, to counter the Amazon idea of everybody compete and get one set of jobs, here's jobs being created in the most rural areas across the country as a result of NIH research. So that's, I think, an important benefit. And then finally, I would say that the next important point in the report is to look at the what if. Had NIH funding from 15 to 17 stayed the same, there would have been a $200 million economic activity lost, 1,400 jobs lost, 18 million in state and local taxes lost in those 7 states. So that if you were to then say, well, project ahead, what happens if NIH funding doesn't increase over what it is today? Well, 2 years from now, it's in order of magnitude, something like that you're going to be looking at. So that the impact is not just what has it done, but what does its discontinuation imply for the future of rural economies. And I think that's a important result. And I don't want to take any more time because I'd like to get into the panel and have your discussions. But again, I'd like to say that to me, looking at it, and it came to me in light of reading all of the hoopla about the Amazon, that NIH funding is the public policy for today, for this time. It's in place. It's not competing, give us your billions of subsidies, build the railroads, or give us tax increment financing, and we'll come. It's, we're already here. We're going to be here more. Your businesses are here, and they're generating jobs in your states today. If that funding continues, that distributional policy will continue. And to me, that's really the only long-term solution for what's happening, has happened since 2010, the recovery from the Great Recession, of the greater concentration in the metropolitan areas of economic activity. So thanks, and I'd be happy to answer any questions, but let's get on to the other panelists.
Well, thank you, Chuck, and a good introduction, because we obviously do want to get to a point where we open it up and make this more of a dynamic discussion and entertain any questions you might have. But before we do that, we are joined by 3 additional fabulous panelists that we're so lucky to have with us today. And I'm going to briefly introduce them, ask them to give just a few brief remarks, and then we'll kind of get into specific questions. So I will actually start, let's see, I've got this reordered. So right next to Chuck, we have George Blough, who is a 28-year ovarian cancer survivor and an American Cancer Society Cancer Action Network volunteer. And George is going to share a little bit about her own personal story and how medical research has been so impactful to her and her family. And so we'll get into that. But I'd also like to note that in your materials, in the state-specific snapshots, particularly the one for West Virginia, George's story is highlighted in there. So you can also read about her experience there. To her right, we have Dr. Donna Arnett, who is the Dean of the College of Public Health and a professor of the Department of Epidemiology at the University of Kentucky. She is an NIH-supported researcher who has spent much of her career studying the genes related to hypertensive disorders and the organ damage that results from hypertension. In recognition of this work, Dr. Arnett received the American Heart Association's Population Research Prize in 2017. And I note she is also a past president of the American Heart Association. So we're so pleased to have you, Dean Arnett, with us here today as well. And then finally, on the far right side, we have Carlos James, who is the Director of Site Operations for Thermo Fisher Scientific's manufacturing facility in Auburn, Alabama, which is part of Thermo Fisher's Laboratory Products Division. Carlos was born and raised in the great state of Alabama, but attended Tennessee Technological University, where he received both a bachelor's and master's degrees in engineering. So I'd just like to turn to our 3 panelists now and recognizing, and this is no surprise why this happened, that we've conveniently gathered what we like to think of 3 legs of the kind of research community stool. So we have the patient voice, we have academic research, and then we have the life science industry, all together kind of bringing unique perspectives. Noting that we actually have one of our guests who's joined us, this is a good moment and transition. So before we get into the panel stories and our Q&A, we're so glad to have one more lawmaker who join us and spend some time with us this morning, giving us a few thoughts, and that is Congressman Steve Womack. And I have to say that the congressman from Arkansas deserves a great deal of credit for the creation of this report, because it was actually in working with his office in early conversations a year or so ago that we started to suss out this idea that perhaps this story of the impacts of NIH spending and research back in rural states and districts isn't as well known. I think this group will be well aware that the congressman is a vocal champion of NIH funding, and we're very fortunate to have him serving on the Appropriations and Budget Committee in the House. And so without further ado, noting that he's got a busy day and I believe a hearing to get off to, we'd like to represent Congressman Womack now.
Well, thank you. It's nice to be able to get to a place where you know you got to speak and they say, hey, get on up there, speak. It's not like Congress didn't have anything going on today, although we really don't have as much going on as we should have. This has been kind of a wasted week in my opinion, but nonetheless, not wasted in a sense that I get a chance to come up here and spend some time with some people that are doing something that is pretty doggone important, I think, to the country. We've made a lot of progress down through the years. I don't think anybody could argue that the National Institutes of Health and throughout the country, and particularly in rural areas, has made a real difference in helping us get past these chronic diseases with transformational research that either leads to cures or slows the rate of growth, and if nothing else, elevates the conversation in the country about how important it is for everyday Americans. Now, I'm the ranking member of the Budget Committee. Last year, I was chairman of the Budget Committee, and we had this thing called an election last year. So now I get to be the ranking member. And I'm also an appropriator, but at every opportunity I have, given the fiscal condition of our country, $22 trillion in debt, $1 trillion deficits, now more than ever, it is absolutely imperative that we seek a return on investment on the things that we are using taxpayers' money for. And yesterday we have the OMB acting director in front of our committee for about a 3-hour hearing, and he got pummeled because of the cuts associated with the president's budget that came out on Monday. But he was trying to make the case, and I agree with him in the sense that even on the discretionary side of government, about 30% of where federal revenues, federal spending actually resides, that it is important that we analyze and continue to look at the priorities of our country from a resource-constrained environment and channel those dollars into the programs that have the chance to help us bend the spending curve in a more favorable direction in the out years. And that's what research does for the country. The problem is, to the discerning people here walking around in my community and in yours, is that if it doesn't produce a desired result today, then many times it's discounted in importance. And we have to get away from that. Again, I'm an ROI kind of guy. I'm looking at what are we doing today that can help us bend the fiscal curve in a more favorable direction, or else we may not be here in the future talking about this, because the country could become insolvent very quickly if we don't analyze the investment grade opportunities that we have with taxpayers' dollars. So, and I've got prepared remarks here. I guess I should go to those, or my staff will beat me up. Today, extraordinary, almost previously unthinkable progress has been made in the fight against chronic disease like cancer and HIV/AIDS. Survivorship rates are continually increasing, thanks to new treatments and cures, yet so much work to be done. What has been the driving factor in medical progress? Continued investment in innovation and research. Overall, NIH funding has increased for fiscal 2019 by $2 billion. Now, I'm mindful of the fact that the president's budget does have some cuts to the NIH. We'll come back to that here in just a minute. But novel medicines have the power to save and transform lives, driving life-changing value for patients and healthcare as a whole. Congress doesn't create cures, but the policies we implement in Washington affect the ability of those experts to do so. And as your report highlighted, NIH research and development is happening in states across the U.S., including my very state of Arkansas. Now, when you think about medical research, you may not immediately think of some of the more smaller rural type states like Arkansas or West Virginia, represented by my legislative director here today. But medical research in my state is not only helping to improve treatments and cures, it's also supporting good paying jobs, partnerships with local schools like the University of Arkansas for Medical Sciences, and economic activity. It amazes me to hear about the work being done in my own backyard. A team of the University of Arkansas for Med Sciences was awarded more than $400,000 from NIH in 2018 to study new ways to repair shoulder cuff injuries. The Arkansas College of Health Education was awarded a 3-year NIH grant for over $300,000 to research the regulation of enzyme processes, which culminates in diseases like rheumatoid arthritis, cancer, and Alzheimer's. And as a ranking member of the Budget Committee, I'd be remiss if I didn't mention that medical treatments will also help us reduce long-term costs. Now, I would caution the president about cuts to the NIH. I know that in the quest to be able to fund other administration priorities, that the money has to come from somewhere. But I think it would be short-sighted and a failure to recognize what research can do to the fiscal condition of our country, not just medical research, but I'm talking about innovative accomplishment, as small as it might be, that I have learned that incrementally on the front end can be dramatic in the out years. If you cure someone with a chronic disease, not only do you change their quality of life, but you've also given them an opportunity to hold a job, pursue ventures that they may not have otherwise been able to do, and that gives you a twofer. That's a more productive person, a person with a better quality of life, and one less person dependent on the federal government. So keeping people healthy will help reduce long-term health care spending and make people more productive. And before I wrap up, I'll just say this. It's easy, I think, for people to become centric on what their view of the role of the federal government can be. It could be defense for some people because it's in the Constitution that we provide for the common defense. We all want to be safe and secure. Or it could be infrastructure for those people that move around the country. They know that infrastructure is a very important thing. And I could go through the litany of requests that I get in my office every single day from people, and they make compelling arguments for why these are important. Some are more important than others. And I would argue that the health of the population, the health of people, and our ability to continue to answer the spectrum of diseases that affect the quality of lives of everyday people is arguably one of the most important things that we can do for our society. Now, I didn't come by this just recently. I was telling the story earlier today of the state health director for the state of Arkansas who was in my office. And I've had this conversation with Dr. Collins at NIH and Dr. Redfield at CDC. But in the late 90s, when I ran for mayor of my city, I promised my silver-haired caucus, and now I'm one of them, that I would build a facility in our city for them. These seniors had given their lives in service to our community, and I felt like it was time that we did something for them. And so I got in a bond issue about $5 million to build what we now call a wellness center, but at the time it was a senior center. And I had an idea of what this was going to look like. It was going to be a whole bunch of people sitting around card tables, playing pinochle or bridge, maybe reading a book or doing a jigsaw puzzle. And I appointed 18 members of my community, 50 and over, to give me what I called a room inventory. I want to know what you want in this building. And I was shocked at what I got in response. It was mainly, we want to enjoy healthier lifestyles. And to do that, we need a place for the 50 and over crowd to go and not necessarily be intimidated by some of the younger ones that like to practice their recreation. So we built it. And on the Sunday afternoon we dedicated it, my director was inquiring of me as to how many people we should prepare for finger foods and drinks. And she said that she thought 300 would catch it. And that Sunday afternoon, 1,500 people, 50 and over, showed up on that doorstep, anxiously awaiting to participate. And now, in its 13th year, it has an unbelievable membership. By the way, we kept the membership at $50 a year. And I have about 12 to 1,500 people a day utilizing it, and it is literally changing their lives. Now, I can't quantify the cost that I believe I have saved CMS over time, but I know it's substantial. But it was evident to me what had happened when I had a little old lady in about year 2 walk up to me in the area now as a coffee bar, but back then there were a couple of pool tables. And she said, "Mr. Mayor, do you want to see a miracle?" And I said, "Man, I'm always up for a miracle." And she goes, "Watch this." And she walked a few steps out into the foyer, stopped, pivoted, and looked at me, and then she came back. And she said, "Did you see that? Remarkable, wasn't it?" And I said, "Yeah." "Help me understand." She says, "See that man over there playing pool?" I said, "Yeah." She goes, "It's my husband. He has Alzheimer's. And since his diagnosis, I have not been able to take a step anywhere in my life without my husband on my hip. This is the only place, Mr. Mayor, on the planet where my husband feels secure enough that he doesn't have to be in my shadow at all times." Let me tell you what we've got to do, people. We got to fix this. You can call them moonshots if you want to, and maybe they are. But the collective ingenuity and creativity and intellectual capacity vested in all sectors of human life in the great United States of America can do this. But it won't be able to do it if we are not able to invest in it. So congratulations for what you do. It's an honor and a privilege to be up here in Washington, D.C., to be an appropriator, to be a ranking member on budget, and to be advocating for these kinds of programs. And I truly appreciate what you folks do every day to improve the quality of life for all Americans. God bless you. Thank you so much. We want to do Q&A. I don't keep this panel waiting because I know they're chomping at the bit. If anybody had maybe 1 or 2 questions, I'd be happy to answer them. If not, I'm going to escape out of here. Anybody got anything burning on their mind?
Looks like you might get off easy today.
Let me tell you something. It doesn't get any better than that. Keep up the good work. Thank you, panel.
Thank you.
Thank you. All the best.
Thank you, Congressman, and thank you for your leadership on these issues. We really appreciate you joining us today. So, all All right, so now we will go ahead and turn, and I just gave a moment ago brief introduction to our panelists. And I'd like to actually just, starting with George, ask if you might spend just a minute and kind of explain to our audience, what brought you to the table today and your own story and why you're passionate about NIH.
I'm honored to be here today. I'm going to give you some insight from the cancer patient lens about research, researchers, and government funding. I'm a 28-year ovarian cancer survivor. I've been stage 4 for 21 of the 28 years. Research is why I'm in this room today. In 1990, my life was saved by a drug called Taxol. That drug started from the bark of the Pacific yew tree in 1962. The drug didn't make it to the market until 1990, where many women, mothers, wives, sisters, daughters died waiting for the drug. The drug didn't make it because the government funding wasn't there. 2 years ago, I actually met a researcher who researched Taxol in the 80s, so you can imagine how exciting that was to still be alive. Over the last 2 years, however, my cancer markers are changing. They're gathering up again, and it appears that it's getting ready to go somewhere in my body. We're just not quite sure where. Will it be tomorrow? Will it be next year? We don't know. But hope is research. Every day that I know there is a researcher out there working on something that just might save my life again is critical to me. But that can't happen without strong government funding. I didn't think I would live to be 45, but thanks to research and Taxol, I'll be celebrating my 73rd birthday this June. My husband, my 4 children, my 6 grandchildren, and I are grateful for the extra 28 years that research has given to me. We need the funding and we need the research to continue.
I feel like we could almost just end there. I mean, George, that was great. What a powerful message. But we won't end quite there because we do have a few other voices to hear from. And Dr. Arnett, I think we're so pleased that you could be here because not only are you an NIH researcher and an epidemiologist, but you've that's done a lot of research in areas related to human health, but you also have the public health perspective. And we've heard a few of our speakers, including Congressman Womack, talk about that interaction and what it means to translate research into not only individual better outcomes for patients, but what that can mean for the health of our communities and our nation. So maybe speak a little bit about that.
I'd be honored to, and thank you for the invitation. I've been continuously funded from the NIH for the past 25 years. I know I don't look old enough. And my area of focus has been in the area of cardiovascular disease, specifically around hypertension in African Americans. So I've focused a lot on disparities. African Americans have the highest rates of hypertension and higher blood pressure levels among those who are hypertensive than any other ethnic group in the world. And they have more target organ damage. So my research portfolio over the last 25 years has been to try to understand the genes that have contributed to that hypertensive heart disease in particular. And we have found some really exciting markers for that. 3 years ago, I moved to the state of Kentucky, where I was born. And Kentucky is an interesting place, mostly rural, more than 50% rural. We have the #1 rate of cancer in the country. We're #3 in cardiovascular disease in the country. And the opioid epidemic really started in eastern Kentucky, West Virginia, and our state has been ravaged by these health outcomes. And so as I've moved to Kentucky, I'm now pivoting my research program to try to understand what are the causes of these conditions And how can we build multi-sector collaborations to try to address the social determinants of disease that are really contributing to this? So I have a grant and review, fingers crossed now, by the NHLBI. There are no Appalachian studies funded yet by NHLBI to look at children, to understand what is it in the child's environment that could be leading to these later conditions. Research in our college has shown that by screening for colon cancer, something that people in Eastern Kentucky don't like to do, we have reduced the rate of colon cancer mortality by 50% by adopting these large screening programs. So we know there's hope, and we know that research to understand how you implement these kinds of screening procedures and how you identify risk factors in our population will help us reduce that burden in the future.
Terrific. Well, I think it's easy when we think about the nation's research enterprise to think maybe, you are aware of the research universities and centers out there and the individual researchers doing projects like those you just heard about, and obviously the patient at the end of the research pipeline. But I think not always as well understood, but as Chuck mentioned, is there's this whole vibrant ecosystem of organizations that touch into this research enterprise and make it possible. And one is life science industry, not only in the drug development pipeline producing new therapeutics, but also companies like Thermo Scientific that's making the research materials and instrumentation that allows the research to actually go forth and take place. So great that we have that perspective represented on the panel today. And Carlos, I'd love if you could just tell us a little bit about your own background and what it is that you all do there at your manufacturing facility.
Okay. Well, at our manufacturing facility in Auburn, Alabama, we produce we produce a bouquet of medical devices. Our primary products are drug test kits for urine, saliva, and hair. We make products for premature babies and mothers that are breastfeeding. That's a patent product under our Snappy Brands product. We make water test vials, kits, and there are only 2 manufacturing locations in North America that makes dairy testing medical products, and we are one of those 2 locations. NIH funding is very, very important to rural areas. It plays a significant role, especially in a state like Alabama. Besides funding the next medical breakthrough, it also provides a very high level of return on investment by providing increased pay for the sector jobs as it compare, as well as boosting the local economy. Thermo Scientific, we are the world's largest analytical instrument and laboratory products manufacturer. We produce everything from latex gloves to gene sequencers. And if you still don't know what we do from that, we play a very significant role in science. Wherever science is being done, and the awardees from the NIH funding need equipment or research help in terms of technology, our company is there providing the support that's needed.
Terrific. Well, I have a booklet full of questions, and we can certainly get to some of those if we've got a shy audience, but we have the room for about another half an hour or so, and I know that some of you might have to peel off at various times, so I really want to go ahead and turn to you. If first and foremost, there's any questions that you have for Chuck about the report and its findings, for any of our panelists, so that they can give their perspectives. Any questions from the audience? I'll get us started, and then maybe you can be thinking if there's any additional ones that you want to pose. So, Donna, I wanted to turn to you, and because I think it's important in reports like ours that we're putting out today, talk about the return on investment argument that we've been talking about at some length. But we don't want to lose sight about the primary focus of this research and what that means for the advancement in human health and outcomes for patients. And so I wonder if you could talk about, and you gave the example in your own research, chronic disease in particular, and how that impacts some of these states disproportionately compared to other communities. And so maybe you could talk a little bit about why that's the case. We have the good facts that Chuck cited already about some of the health disparities in some of these communities. But I think having a better understanding about how the NIH research plays into that dynamic would be very useful.
Okay, great. Well, it's interesting in that most of cardiovascular disease and cancer are preventable diseases for the most part. We know that in the cardiovascular space, up to 90% of cardiovascular diseases could be prevented. And it's prevented through adopting a healthy lifestyle. One of the challenges, and one that I think we have to address is within the NIH research community, is how do we get people to adopt healthy lifestyles? How do we get communities to partner together to make resources available? In this age of advanced data analytics, how do we utilize platforms like Amazon or Google to try to find innovative ways to meet people where they are, to understand how to advocate and change their health? In rural settings, it's easy for us to say, you should eat your fruits and vegetables. Well, it's not always easy to get fruits and vegetables. It's easier for us to say you shouldn't smoke when tobacco growth has been one of your areas in your state for many years, and there's a whole culture around that. So we need to start as NIH researchers meeting people where they are and addressing those questions that can really transform health.
Great. George, you said something in your remarks which I thought was just perfect, and I'm going to steal it going forward, I think, which is that research is hope. And for patients and their families, that's so obviously true. But tell us a little bit more about that. You have your own lived experience, but I'm sure that you've met countless other survivors as you've been an advocate working at your state house here in Washington, et cetera. And through those interactions you have with fellow survivors and their family members, explain to us how important that is, that hope element, and how research feeds into that.
Well, I think that, as I said before, research is why I'm here today. It's the driving force that creates hope for anyone that has a life-altering or threatening disease. I think it's really important, though, that if every person knew the history of their drug and knew the journey that drug took through the research from its beginning to once it reaches you, I think that they would be also an advocate, as I am. We all have the capacity to have a life-altering diagnosis, so no one is exempt. And I think that what most patients don't understand is the power of their voice. The stories that we tell to our legislators and to Congress, and we tell them the importance that research is making. I'm not a number in a book. I'm somebody's wife. I'm somebody's daughter. I'm somebody's grandmother. Without that input, things kind of get foggy. They get lost. I think that people also don't grasp what research is. Cancer patients think it's that building in Bethesda or that building in DC. They don't understand that research is actually when you go to your healthcare professional and you get a drug, or you have to go for a test, or you're diagnosed with a disease. That's research. That's as a result of research. So for all cancer patients that I have worked with, we fight for research because we know without the government funding, we are not going to succeed. We have to continue to fight for it.
Yes, it does. I think so. Yeah, please, go ahead. Jump in.
Something to that, because I was also, I'm going to steal that, research is hope. But I had an interesting experience on the other side of that coin, not the recipient of the researcher, but the research being done and the life that had. I'd done a lot of work with the Jackson Laboratory, which is the largest recipient of NIH funding in Maine. And also the largest producer of medical used mice for research activities. And I was at the lab one time and I met a woman who had come back to Maine. She was a postdoctoral Ph.D. researcher, gotten an NIH grant, came with her whole research community. And I said, it's just wonderful that you're coming back here. And how did you get here? And she said, I graduated from high school in Washington County, by some respects, the poorest county in the United States, the Far East, right across the Bay of Fundy from Campobello. I was a high school graduate. I went to the Jackson lab, took an entry-level job as an animal technician. Basically, she was a mouse shepherd. She watched mice. She was inspired. She was trained, 13-week sessions. First year she worked after high school, 13-week session. After that, she was supported, continued while she was working, got a bachelor's degree, continued, got a master's degree, left, got a Ph.D., left and became an academic researcher. And when I talk about hope, I'm thinking also of the young children in the poor rural communities with models other than growing tobacco or smoking cigarettes, but doing research. And it's not something that has to be started once you get out of college. It's something that, with companies like Carlos's, hiring people who are exposed, given a career path, something that since the herring industry disappeared in Washington County, there wasn't much there. And talk about the opioid crisis. So to me, that story is equally true in giving hope to young people on the research side of it.
Well, that's a great point. And I want to actually come to Carlos here in a second and talk a little bit more about the point that you raised earlier, Chuck, about the high-paying nature of these jobs in this industry and how that can build economic engines and clusters in some of these communities off of research universities, but also industry that's already in place and benefiting from the NIH ecosystem. But before we do that, one other thing you said reminded me of an obvious point, which is, the NIH grants that go out to institutions and to researchers play a huge role in the training and pipeline of the next generation of researchers. And I see you're nodding your head vigorously, Dr. Arnett, and obviously as a dean, so someone who thinks very deeply about the future of the next generation of public health professionals and researchers. I wonder if you could talk a little bit more about that so that the audience has a better understanding about how NIH dollars actually do play a role in the education and training of these professionals as well.
Yeah, I'd love to. I actually was the director of what's called a T32 training program when I was at Minnesota, which was geared to train the next generation of genetic epidemiologists, which is what my field is. So training is critical, and we have to start even earlier in the STEM field in particular to attract people to that field. But we have to have this technical workforce for the jobs of the future to be able to guarantee that return on investment. We're losing now as a dean, I know we're losing to the business community, we're losing to the legal community, and people are leaving the STEM field. And we really have to aggressively find ways to promote STEM and train people in the STEM field so that we can keep the research going to save people like George.
Good point. So Carlos, I want to come back to you, and I'm just curious in some of the findings of this report, talking about how, especially in a community like the one that your facility is located in, I imagine that you're probably one of the better employers in the area as far as the level of skills jobs that you're providing to those communities, and you have those conversations as you do workforce, and you try and bring in new talent and you build the talent in those communities. Maybe talk a little bit more about that, because that's a big piece of the kind of multiplier effect out into these communities.
Okay. Well, I have to say NIH funding, supporting NIH is a top priority for our company. 83% of the budget for NIH goes out the door every year, funding contracts and grants that funds research that impacts every state and almost every congressional district. For the state of Alabama, per the report, in 2017, we had 644 institutions that received some fundings via NIH, and that totaled $300 million. That $300 million resulted in over $700 million of total sales for the state. 4,600 jobs, $54 million in revenue. Specifically for my factory in Auburn, Alabama, we work locally with universities like Auburn University, War Eagle, and Tuskegee University, which is right down the road. We also are partnered with local community colleges. The reason for partnering with them is to develop the talent, to work with them on developing the curriculum that's needed to support the type of jobs that we have. In the state of Alabama, the rate of pay for our type sector jobs paid 2.4 times more for our sector jobs, and for the younger workforce is even higher, 2.7 times higher. So it's a great field. And speaking of STEM, we also work locally with the Boys and Girls Club, exposing them to STEM, the science, technology, engineering, math, and getting them involved, taking them around through on factory tours, getting them excited about the possibilities in that area.
So I've got one or two more questions, but again, if anybody has a question in the audience, we can open it. Yeah, please. If you'd like, go ahead.
Hi everybody, my name is Abigail from the Congressman in Maine, also a Maine resident. I guess the question might be directed towards you, but if anybody has any insight, please go ahead. We know that another thing that rural communities have in common is their challenges with accessing infrastructure, in particular broadband. I'm just wondering if you know how that plays into making the most out of the funding that researchers in rural states receive from NIH, just their ability to produce quality research because of the struggles that they have accessing infrastructure and broadband.
Well, certainly, to me, the fascinating example of that is that since the sequencing of the genome, there's been more data analyzed at Jackson Laboratory in the last 6 months than there had been in the 70 years since its creation in the 1920s. So the need for information technology is critical. I mean, it's the equivalent of test tubes and Bunsen burners and whatever exists. And further, to the extent that that can occur in small rural areas, that's excluded, largely because of well, get 10 people on the road and I'll string the wires down the road, but if you only got 6, then you got nothing. And some vehicle for the last mile infrastructure to an area, and I don't think it can be every area, but just like NIH funding creates the cluster around which activity can occur, then that ought to be able to bring in the high-speed internet that facilitates that, so that it's a combination, just like rural hospitals become the center for a community. The location factors driving facilities are very important.
Well, and Dr. Arnett, you are no stranger to big data, right, in your field. And so I imagine in trying to work with outlying research participants and engagement and those kinds of things, you think through some of these kinds of challenges.
Yes, and absolutely. In the state of Kentucky, there's a group called SOAR, Saving Our Appalachian Region, and there's a big push towards making broadband available to every person in Kentucky. And actually in Moorhead, one of our rural areas, we have better broadband than in Lexington itself, but still 39% of the state is uncovered. So where we really need to I agree we have to grow broadband. I think from an economic just jobs perspective and making that available to all our citizens, it's imperative. But we still have a lot of research questions to ask and answer on what is the utility and benefit of telemedicine. Like, how do you set up telemedicine? Are the outcomes equivalent if you have a telemedicine approach? So if you randomize people to going to a local physician or doing telemedicine, do you get better outcomes if you have access to specialists? We don't know the answers to those simple kinds of questions yet. So there's a lot of research that will and can be enabled through that broadband adoption.
Great. Any other questions? Yeah, go ahead.
There's been some discussion, lately, some of the drug price hearings that the Finance Committee in the Senate regarding how the NIH could recoup some of the earnings that drug companies make based off patents the NIH, based on research the NIH has done. Can you talk to your knowledge of the feasibility of doing that?
I'm not I understand intellectual property, but I wouldn't feel confident that I could address the legal ramifications of intellectual property and property sharing. Traditionally, it's been held by the institution and shared with the inventor. I know in the American Heart Association, we were making moves towards attempting to do that very thing when I was president. So I can't answer, but it's a great idea.
Well, and it is a great question, and I think, certainly right on the nose as far as where the conversation is. I think in a lot of the drug pricing conversation, we unfortunately don't have anybody with us today, I think, who's kind of from a commercialization tech transfer office background. But coming from a research university and medical center, I can tell you that is a holder, right, of IP, and then you license that out. There is a general understanding and that this is a partnership, right, with when federal dollars come in to fund research. But I think, the concerns and questions then become about, you obviously don't want to stymie the innovation pipeline. And that's a line that you hear from biopharmaceutical companies, right, all the time. They're never not going to deploy that argument. But I think it's an argument that actually holds true for other elements within the pipeline and ecosystem as well. So when thinking through some of those questions, I would just invite policymakers not only to think about, what's the implications for a big pharma company, say, but also for research labs in academic settings that may be working with in development of some of these drugs and devices and technologies. I know that doesn't really directly answer the question, but was there another hand that was up over here? Yeah, go ahead.
Hi, everyone. My name is Madison Catherine from Economist office. Thank you all for coming to speak with us today. This question is directed more towards Mr. Lawson. In many of these little states that this report was published on, the opioid crisis is very prevalent and affecting many jobs and health aspects of these communities and the economy as well. So if you could just briefly speak on the NIH's role in that and what research grants and how those have impacted these little states.
Well, I certainly agree that it has affected the rural states in Maine as well, shares in that. I think that and I'm not sure this is so much an NIH question as it is a public policy question about directing resources towards recovery, towards treatment for the victims of the opioid crisis, which I think is a budgetary challenge at the local level, but I think can be, and I know in Maine is being addressed with an effort to try to include that, to expand Medicaid coverage. As to, I think it almost gets to the patent and drug approval process in terms of what to do. How can we avoid the overuse of drugs in ways that are not intended? And so in that sense, it's a regulatory question. But I think in the immediate term, it's a health care crisis question, and that really challenges the fiscal, how much money are we going to spend on taking care of people and how are we going to fund that at state and local levels?
I would just add that, I think many of us in the research community are very grateful for what Congress and appropriators have done the last couple of years to provide some additional resources, not only for medication and assisted treatment and those kinds of things on the treatment and prevention and recovery side of things, but in the research space too. So we have a better understanding of how to address. There's just one example that comes to mind from my home institution in Tennessee that I'll cite. So we have researchers that have received support from NIH doing work on neonatal abstinence syndrome and trying to figure out the prevalency of that problem, what populations that affects most notably, and including in rural areas. And then, of course, what are the treatment modalities to best address that situation?
If I could just add from a factory standpoint, our factory, we've been in existence for over 15 years, and we've experienced a lot of growth. We grew from 30 people up to over 140 people, but that the sustainability to be there that long is a direct result of NIH funding and partnering with our customers, providing them with the products that are part of the research and development that falls from NIH funding, and the extended value chain as well that Chuck mentioned earlier is a huge part of the support that goes along with the 140 people for our site location. So it's big for our location in Auburn.
So we'll entertain one more question from the audience, and then I've got one more to close this all out. So go ahead, please.
My name is Sarah Casalan from Senator Susan Collins' office. I'd like to follow up on this point on health benefits. So we know that for both pharmacological and non-pharmacological interventions, from the time that NIH study shows that it works, there's a large implementation lag of about 17 years on average. What can we do to shorten that lag, particularly to bring these treatments and cures to rural states?
Donna, George, you spoke a little bit about that in your own lived experience.
Well, I think like with my drug, it took my drug 30 years. It started from the Pacific yew tree, the bark of the tree. And in order for them to actually synthesize the molecules so that it could actually be used in cancer patients, it took 30 years. Most of that was government funding. But other parts of it where people didn't think about, you can't cut down all the Pacific yew trees and harvest their bark, because then you have another whole population of people who don't want that to happen. So I think that the only thing that we can do is to continue to hope. I use the word hope again. And for those of you that are going to steal that, I want you to know that hope is the belief that things will get better. So that we can hope with research that things will get better, that more people will go to school and learn how to become researchers and have an impact on the community. All of those things, I think, collectively will make the path of the journey of the drug shorter, but we certainly can't afford to use less money and expect to have better results. I mean, that's the bottom line. I think that's really the critical part. Did that
Yeah, and Dr. Arnett, I think you wanted to jump in as well.
Yeah, it's called the Valley of Death. We have great research at the basic science level. Much of it happens at NIH. Much of it also happens in pharmaceutical companies. And then you have the drug when it gets to phase 3, and there's this valley of death between the basic finding and the translational piece. And I think NIH has been really instrumental in creating these centers for translational science called CTSAs. And I think continuing that work so that we get more investment in that valley of death where things go from being a molecule into testing in animal models, then testing in humans, and then getting it out into larger clinical settings.
And if I could just say something, just with ovarian cancer, with the fact that mine is regrouping and probably going to be back, I went online and looked. I only go to NIH and NCI and cancer.org. But I noticed that if you look on the line of the graph, in 1960, there was literally 2 drugs. Surgery was your option. As you come farther across in 1994 and above, you'll see that it looks like tree branches now coming out of the line because there is more research. People are studying the drugs and they're getting faster results. So I think that the more that's out there, the better the cancer patient is going to be. I mean, for me, in 1989, Gilda Radner died of ovarian cancer. That's not true today. Women can be diagnosed with ovarian cancer and still live. My physician, my oncologist just told me, George, I can treat you into your 90s. There's so many choices out there. So we can't take those choices away. The funding is critical so that those choices can grow and the students can learn and the people who are making the equipment for the people and the economics. So it all fits. It's like a puzzle. It just all fits.
So I'd like to maybe close out with one question that I'd invite any of our panelists to answer, including you, Chuck. And that is, one thing that in the context of our friends up here on the Hill that they think through these questions about government funding for a variety of programs, including research accounts, have to contend with every year is, there's always various different budget pressures. And, we just had the budget proposal come from the White House just earlier this week. How important is some degree of certainty and a kind of clear path forward when it comes to research funding? Because one thing I think we as a community have tried to advocate for is that steady and sustainable is what's really required. We love the sugar rush, sure, when it comes, when you get a big injection of new resources, but far more important, I imagine, but I'd love to hear your all perspective, is what that kind of upward growth curve on an investment for this kind of research means. And not all of you have to respond, but if you've got something to say to that, I'd welcome it.
I would love to say something about this. and I didn't know about this question in advance, but I started my career when NHLBI pay lines were at 10 percentile. And during my career, they've gone up to as high as 28. They've gone down to a low of 8. During the NIH doubling, it was great, but after that we had a cliff, and for years people could not get funded. If you don't get funded, you don't stay in an academic career, and you lose all of that resource that we've invested in training and building the next generation. So having stability of funding that keeps up with inflation keeps that pipeline going. We don't have to stop and restart again. It's really critical.
Yeah, and when you were talking about the valley of death, I've also heard it referred to as the what if shelf. Well, that's the if only we get funding, will this drug then go to the next shelf? So, there are, just if you can envision that how many drugs are out there that are sitting on that shelf that could maybe make a total difference in how medicine is done today is phenomenal. So, it's the what if. What if the funding is there? Well, let's not make it what if the funding is there. Let's see that we put the funding there. And the way we do that is people like ourselves contacting our congressional representatives, our senators, and saying, this is important. This is the point you brought up, is another thing. If we don't have researchers, pretty soon when that money dries up, nobody's going to go into research. So then what happens? Who's going to research the drug? So it all fits together.
Yeah, please.
To me, the answer to that question is the inequality of cuts. We face budget crises and trade wars and inflation and business cycle, and all of a sudden there's a pressure, we got to cut the budget. And in that, every dollar is a dollar cut. But in research, there's a momentum that's lost. It's not this year's dollar to make up this deficit. It's the hidden dollars, the what ifs that we talked about here. And it seems to me that has to be the context with which advocates approach their representatives, to make it on this is not just a dollar towards saving a deficit to make your budget. I know in Maine we're down to June 30th and August before budgets are made, but this is a dollar that's $10 in 3 years.
Mm-hmm. You might be being charitable. It's normally, even after the fiscal year is over, I think, around here where we finally get that all nailed down. Well, I want to thank all of you for joining us today. Note for you that hopefully you saw those copies of the reports here in the room. Our website, unitedformedicalresearch.com, has the reports as well as a number of different other resources and tools we hope will be useful to you. We even have a state infographic that you can pull up information state by state, NIH facts and disease-based facts. If we, as UMR, can ever be a resource to any of you, your organizations, your offices, please don't hesitate to reach out. And please, before you leave the room, join me in thanking our panelists.